So thanks for coming, guys. Obviously, it's a little more challenging these days to meet it out. My name's Adam Miller. I'm a foot and ankle orthopedic surgeon at Beacon Orthopaedics. We have an office literally right above you. And so I'm here on Thursday mornings usually. There's one of us always here that's trained in orthopedics across the board, but the way things go over time, you start subspecializing, and pretty much all I do at this point is below the knee stuff. We do see, obviously, urgent care things that come in, but tonight we're going to focus on foot and ankle. I want to make it interactive. Doesn't have to be, but if you have something you want to ask, just yell at me, raise your hand, get my attention, and we'll go through that. We're going to talk a couple different avenues. One is about common things you might see or be acquainted with that you feel in and around activity and sports club activities that you're doing, and then how to prevent those. And then also, what are some of the things that I encounter that we're doing to try to make your lives better if something bad happens? So we'll kind of go through all that. I picked out just a small handful of things. I do over 100 different types of surgery, so we're going to focus on the most common types of things that you might see and encounter in kind of a sports lifestyle. So we'll just kind of rifle through some of these to begin with. Let's start with just at the top of the board here, shin splints. So everyone's heard of this. They've heard of this whether it's in high school when you've started, or maybe it's just later in life when you're trying to get back to normal routine. What are shin splints? So if you think about the bone in your leg, you have two bones in your leg. One is the tibia. They always told us in med school the bigger one is the 2-ton tibia, so that's the big one. And then you have the smaller one, the thinner one, which is the fibula. Sometimes when you're doing activities, the challenge in doing more activities or something new that you've already done, and it's too much for you at that time, there's increased inflammation, there's increased stress around the bone. Now, the bone is a living and breathing thing. It bleeds just like other parts of your body, and it has a lining almost like a tree bark to a tree, and that is called the periosteum. And so that is the area with which gets inflamed, irritated, and that is the phenomena of the shin splints. So what you're actually getting in shin splints is not a stress fracture. The bone is not broken, but it is irritated because the lining of the bone is irritated. And so what this picture is just trying to depict is just that irritation, and that's a common area that you'll get it. It's very diffuse. And what I mean by that is the whole bone tends to be painful. It's not just no pain, ouch, no pain. It's kind of, it's pretty much painful the whole way up and down the bone. And that's one of the ways that we tend to characterize these injuries. If I'm seeing pain in one focal area, then I worry more about a stress fracture. But it's much more common to have shin splints than a stress fracture, and that's how they present. So if we feel that you do have shin splints, what do we do about it? A lot of this is very mundane. People come in and want to go, and they don't like this conversation because a lot of shin splints is just letting it be and letting it go. So that means, yeah, your RICE, you're going to rest, your ICE, and all that other things, compression elevation. You guys all know that probably. I try to break it down in terms of how bad it really is for you. So if somebody comes into my office and they tell me that they cannot walk without pain, that means to me that it's more challenged and we need to protect it. I want to get you into an environment that has no pain. So we'll put you in a boot. But if you can do things, let's say you can walk, but doc, it only bothers me when I'm running or when I'm on the treadmill, then we just modify those activities. We want to make sure that you can get around in a pain-free environment. We try to continue that process for a couple weeks, and if you can get pain-free for a couple weeks, then we start to slowly advance you. Okay, number 2. So this is a very common one, even more common. Achilles tendonitis. This comes on in a couple different names. Achilles tendinosis, Achilles tendinopathy, Achilles tendonitis, tomato. It's pretty much the same thing. There's a couple different areas that people come in with pain on the back of their heel. So you're seeing a pretty large one in the back over here, but this is the most common area here. This is the heel where the Achilles tendon inserts in the posterior aspect of your ankle and foot. Sometimes people will experience pain up in this area. and this is called what we would say is the mid-substance, or the actual Achilles tendon. It's much more common to have it down here. Now, the Achilles tendon, longest, strongest tendon in your body, so a lot of stress goes through that area. And because of that, a lot of pathology and problems occur with it. Usually, we kind of associate this with repetitive routine activities. To be honest with you, why does this happen? We have no idea. It's probably a combination of most things in life, genetics, plus environmental activities and what you do in and out every day. But we really don't know why some people develop pain at the insertion of your Achilles and then some people don't. It's a common cause, though, of pain and injury. We see this a lot in the clinic. So, when people come in, what do we see? Well, they're going to be painful. They're going to be somewhat stiff when they walk. They might walk with a little get up in their gait. They might have some swelling in the back, almost like, Doc, I'm hiding a marble in my heel. Sometimes it gets to be pretty voluminous in how much thickening's in the back there. When we start to look into this, and what we see on some of the exam, and then into the imaging is characteristic. So this one's pretty bad. This is a person right here. This is the back of their heel. This is the actual ankle on an x-ray. So you're looking at what we would call a lateral view of the ankle here. And what you're seeing is the calcaneus, and that is the bone to which the Achilles inserts. And you don't have to be a radiologist to think that all this is pretty aggressive and big. This is abnormal. This is actually bone that is generated within the actual Achilles tendon. And so over time, repetitive stress, activity, things start to culminate over time. And you develop these basically bone spurs that live in the tendon. And it also is at where the tendon inserts. So normally, you wouldn't have any of this. You might have that a little bit less of an angle there. But all that is that degeneration within the tendon insertion. Now, if we look at on the right side of your screen there, that's an MRI. So that's what we would call a lateral or a sagittal view of the ankle and the heel. And if you look at this, basically we're seeing that same bone process in here. Now this is the tendon, nice and dark. Nothing really wrong with it right until we get over here, though, things start to change. So these are some of the diagnostic tests that we use to really characterize how the severity is and what we're going to do about this if things initially fail. So what do we do with this? Well, if you're just coming off the street and you've not tried anything, we're not just going to jump into surgery. That's not the right thing to do. What we want to do is try to maintain your level of activity if we can and improve it. If not, temporarily modify that in hopes that you will get better. And I will say the vast majority of people do get better despite some of these changes. So we're going to focus on a lot of flexibility. This is in the gastroc, the soleus, all the muscles that are attached in your calf to the Achilles tendon. Sometimes if it's really bad, we will put you in a walking boot, the dreaded big gray boot. When do we go to the big gray boot? Usually it's when you tell me that it's every step of the way. If you're not able to walk and do all the activities that you want to do, and it's not intermittent, it bothers you pretty much all the time, you're probably going to be recommended to get a boot. But some people do fall into that other category. Sometimes it's only when I'm running. It's only a minute 7 on the treadmill. Those people we can try to work with. We can try to get you into physical therapy. There is often a measure for what's called a heel lift. So I often equate that to like a high-heeled shoe. You know, and the women, they understand that. Some women will just come in. They've already figured out that their high-heeled shoes and their dance goes or whatever they're wearing are better than their flat tennis shoes. And that's because you were relaxing the Achilles tendon. You are not asking it to pull so much on your heel because the heel is already in that position. So those are some of the measures that we initially try. And I try to deviate it between how much pain you initially have. If we get beyond some of these things, and then we're scratching our heads saying, okay, the boot didn't work, and all the PT didn't work, and I really don't want to go to surgery, what else we got there? There are a couple options. It depends on how big and flowering some of those bone spurs are. So if those bone spurs have their own zip code, they're probably not going to get improved by some of the measures I'm going to talk about here. And then we would think about recommending a surgical intervention. But if you're kind of in the middle, which is a more consistent and common type phenomenon, the bone spur is not as big, then there are a couple alternatives. One is called 10X, and that's a procedure where a physician will put a needle into the area of the tendon and the bone spur. And what they try to do is create some local irritation and inflammation in that area, such that the body reacts, responds, and then tries to heal. In a similar fashion, what we call shockwave therapy, down here, ESWT, what that does is, it's actually pictured on the right side here. We are attached to a machine, we have a probe, and that probe is placed on the heel. It's completely transcutaneous. There is no actual intervention through the skin, and it's what I equate to like a painful massage. Somewhat irritant when we do it, but it creates some local irritation and inflammation in the tissue to hope for the body to say, oh yeah, hey, there's something going on here. This isn't just a chronic phenomena. There's something acutely bothering you. Let's come down here and have the immune system heal it. And then finally, we always talk about hot button topics such as PRP. You may have heard of that. What is PRP? Platelet-rich plasma, that's an acronym. And it's commonly talked about in orthopedics and other biological medicine. PRP is your own blood. So if you go and get a PRP shot, they will actually draw your blood, about 50, 60 cc's of fluid out. And they take it into a centrifuge, concentrate it down. We take the platelets and the coat where growth factors are attached to the blood natively, and then we actually use that and inject it into the problem area. So that's been looked at and researched in many areas. Achilles' tendon is one of those areas. It's not the greatest spot to put it in, but it is an option. And after those, we will usually immobilize the patient for a period of several days before reactivation. And of course, surgery. Surgery, what do we do in these cases? We will debride the tendon. In other words, open it up like a book. I will clean out all the diseased portions and then remove all those bone spurs. Take those away. And then we reattach the tendon. All right. So, Lisfranc ligament tear. What the heck is that? This is actually a fairly common injury in more, I would say, high-intense sports, but it also can happen with you twisting your foot down a flight of stairs. It often just takes the right angle and the right amount of force in the wrong way for these injuries to occur. Most of these injuries, actually, somebody will say, oh, I got some pain in the middle of my foot, and it's just not going away, and somebody goes to the ER and they miss it, and 1/3 of these are actually missed by an emergency department, simply just because they're very subtle injuries in most cases. But usually, as you're looking at in this picture on the right, there is a force directed on this foot, what we would call axially. So somebody falls on the foot, there is some awkward twisting mechanism that there is an axial, what we call a direct force, right through the column of the foot. Now, where is this? So if we look at the anatomy of the foot, which is on the right here, and then we focus on this area here, that is the area where this ligament lies. So think of this. There is an arch in your foot going this way, and there's an arch in your foot going that way. And this ligament is kind of the keystone to that Roman arch, if you go back to history class. Without that keystone, then the arch falls, and in like manner, so does the ligament play that role. If the ligament tears, we know over time, very consistently, the arch of your foot will fall and you will get arthritis. So this is an MRI scan of a Lisfranc ligament, and you can see it right here. That is what we call the interosseous, which is the strongest component of that ligament. What this is trying to show you is this arch in this direction. That is a cross section there. Hence the Roman arch. Now what happens when you injure that ligament? So it doesn't have to be this much swelling and pain. and bruising and such, but this is a classic appearance. You will get bleeding into the foot with the ligament tear. You will get bruising on the bottom of your foot. If you do some awkward twist, you're like, oh, my midfoot hurts, and the middle of my foot hurts, and then you look down and there's some bruising in your foot, that should draw a question, I need to have this looked at by somebody. But the swelling is also consistent in this time frame. If we look at imaging, and I will put a little arrow here, this is what I would call a normal x-ray, or before I move the foot in the OR. This over here is not. That's after I'm moving it. You can see my hand up here. And so what's happening here is I'm twisting the foot in the same mechanism of the injury. And I would argue that that space is more than that space. And that's kind of how subtle these can be, which is often why they're missed. So, going back to that same position of the MRI, and now let's just take a look at the difference. Ligaments are supposed to be thick and black, and so if we look at thick and black, and then we don't see that over there as much. And all that light area in the bone is swelling, bruising, which goes along with the injury. Okay. We try to characterize these as being either stable, in other words, they will heal on their own, or the ligament is unstable. And it really goes down to the degree of the tear of the ligament. Let's just say that it is stable, and we declare it stable, then you would be initially into a boot, and we kind of call this a sprain of the ligament. So you'd have a midfoot sprain, and you'd be in a walking boot. And you're allowed to weight bear on these, but we slowly watch your pain improve, and it's not something that takes days, but usually takes weeks to get over. Once we feel that you're comfortable in the boot, then we try to get you out of the boot into a stiff-soled shoe, sometimes an insert, something that provides some support, such as something like this. But a lot of these do demonstrate instability. In other words, the ligament is incompetent. We decide that it's not going to heal on its own, and so to prevent the collapse of your foot, to prevent the arthritis that's going to come on, we do surgery. And this is just showing a couple of different things and hardware that we might use, but the basic idea is that we either fix these and let the ligament heal at the appropriate position over several weeks' time, or we do what's called a midfoot fusion, and that says, okay, there's no way this ligament's going to heal, or the chances are unlikely, and so we just make the bones grow together. In other words, no more need for a ligament. We make the bones fuse to one bone. Okay, so this is just showing a couple of pictures that there might be a couple of hardware sequences we use, but basically you're using screws, plates, something like that to hold the relationship. If you remember where that x-ray was, that's where the ligament would be. So all of these designs are just trying to hold that relationship together so that the ligament would heal over time. Just one other option there. You guys good? Any questions? Okay. If I'm going too fast, let me know. Okay. So this one, everyone's probably heard of, plantar fasciitis. Well, what the heck is plantar fasciitis? Well, it's a big pain in the butt is what it is. This is probably one of the most common things an orthopedic surgeon sees. It's one of the most common things that you guys will encounter here at the sports club. It usually is characterized by pain on the bottom of your foot. The most classic area for this is in the heel. Although, as you can see from this picture here, the plantar fascia is a cord of tissue that starts at that heel bone. So if you remember, the Achilles was up here. Plantar fascia starts here, and it goes all the way to the toes. So it's possible to have pain here, but it's also possible to have pain over here in the middle of your arch. We call that the mid-substance of the plantar fascia. But in often cases, this will start as you get up in the morning, get up from sitting at your desk. That's the textbook answer. People will describe pain with startup. Sometimes it will improve, over several minutes, half an hour to an hour, but it often does not go away completely. And in significant cases, it's more consistent. What are the risk factors for this? Well, we believe that if you have some sort of tightness in your leg, in other words, you have loss of motion in your ankle, loss of motion in your knee, even a history of back problems, back surgery, that creates tightness in the hamstrings, and that can lead to something like this. Obesity, if you think more weight up there, more pressure down there. That's something to think about. We try to associate this with a high arch, but I mean, it can come in any factor, but high arch meaning that some people walk more heel-toe, whereas a flat arch, you'd be more approaching the inside of your foot, and there's more even distribution of the weight in your foot throughout the foot itself. But also the type of activity you're doing. So if you're not, what we would say, very flexible and you're doing repetitive activity, interval activity, new activity, these are all potential risk factors. But just like the Achilles tendon issue that we were talking about, we really do not know what causes this. So, all right. Oh, this is an important point. Down at the bottom here, and all in the big italics, people really want to harp on bone spurs. A lot of people come in worried about the bone spur they may or may not have, or maybe they got an x-ray at their primary care, and they saw they had a bone spur. In most cases, doesn't really matter. There's not a lot of research out there to say that the bone spur itself is the phenomena that's causing the pain. We tend to relate that more to the actual soft tissue that actually attaches to the area of the heel. Just a little FYI. Okay, so as we talked, tender along the heel itself, and then Aquinas Contracture. What does that mean? Well, you have a tight calf. So you can't dorsiflex your ankle past neutral. You're rotating your foot out, you're externally rotating it to accommodate that. There's a couple of things you can look at, but essentially tight calves. And in almost every case, the x-rays are non-contributory. They don't show me much. They're just basically ruling out other possibilities that this could be. Usually, when I'll see somebody like this, we'll try some basic treatments, which I'll go over. And if we fail on some of those treatments, sometimes we'll get an MRI. Why do we get the MRI? Well, I want to see what the integrity of the fascia is. Is it torn? What's the grade of the tear? Is it pretty significant? Is there anything else going on? So that's really the utility of an MRI. That's not a first-line thing. All right. So how are you going to treat this without coming into my office? This is probably the most important slide, since it's the most common treatment you'll have to do on yourself. So flexibility is key, the stretching in your calf and foot. I can't stress that enough. There's a couple different stretches that we can go over a little bit later, but basically the idea of stretching out your calf and also stretching out the fascia itself by crossing your knee like this, sitting down and pulling the toes back such that you can feel that tightness in the bottom of your foot. Some sort of insert usually helps somebody. It is not one size fits all. I would equate it more to trying on a glove. Everybody's a little bit different when it comes to what fits in their shoe and what works for them. But the important point is that you're just trying to offload the area of your pain, and what these inserts do is it redistributes the stress in your foot in a couple different areas. A night splint. What's a night splint? That's a night splint. Okay, so when you go to bed, we all sleep with our toes down. Nobody keeps their toes up. That would be a whole lot of effort while you're sleeping. So to avoid sleeping in that position where the plantar fascia is contracted, so you think about the foot down, the bottom of your foot is relaxed, we would put on a night splint, and that holds you at a 90-degree position. And so the hope is that it's almost doing some stretching of your foot or maintaining that position while you're asleep. And then, of course, we'll try some basic anti-inflammatories. Those can be topical or oral, depending upon the situation. And then we go into the ESWT, which is that shockwave therapy. Again, there are several other options as you get deeper down the line, and sometimes these things fail. Injections. Some people come in and are like, oh, just give me the injection. I heard my friend Joe had the injection, and it worked great. I got to get the injection. Injections per orthopedic guidelines, we usually try to say, well, try one, see if it works. Several repetitive injections is usually frowned upon. simply because you'll diminish your fat pad in the heel. And if you end up with no fat pad and walking on bone, that is not a happy sight. I've seen that before. But usually try it. Sometimes it works, sometimes it doesn't. It's not usually first line. Sometimes we'll try the stretching first, but it depends on what you come in having tried and not tried. You look at this slide here, and yeah, you'll see that PRP acronym again. That is something that we commonly discuss for recalcitrant cases. People, they can't get rid of this. People come in with 6, 8, 10, 2 years of this pain, and we start thinking about alternative options. Surgery. I've seen people come in having had surgery and they're like, yeah, worked pretty good. You know, I'm feeling pretty good. I've had people come in, I have nerve pain, I can't walk, my foot is ruined. So it's variable. Depends on which research you read, but in most cases, as a broad generalization, I would say most orthopedic surgeons, in other words, in my spot, we tend to be more conservative with it. We don't really do a lot of surgery on this because we can see the downsides to the surgery. Whereas a podiatrist, which is a totally different realm of way of teaching, sometimes they advocate for more surgery, but that's a broad generalization. In my opinion, I don't like to do a lot of surgery on this. I think you can treat it in different ways. Okay, so we talked a lot about this already. The heel cups, anti-inflammatory stretching. We'll just move on from that. Oh, these are the heel cups. These are nice. It's worth trying it. So if you don't like the full-length orthotic, like Miller, I tried this stuff. The orthotics are wasting money. You're wasting my time. Try this instead. These are a quick, easy find at Walgreens or CVS somewhere. Yes, we already know. Here's your night splint. Okay. All right. Moving on. Ankle sprain. What happens with an ankle sprain? Well, you're doing some activity and the ankle falls off its axis in one way or another. The most common being what you're seeing in the picture here, and that would cause a lateral ankle sprain. These come in different grades. You can walk away from them and never see my face ever, or you can not be able to walk and you're on crutches. Obviously pain, swelling. Usually bruising does not come on immediately. That's kind of a day or two after, sometimes even longer. Obviously it's tender. If you get enough of these, you end up getting something called instability. What is instability? Basically just means the ligaments attach bone to bone. Tendons, just for clarification, attach muscle to bone, sort of like ropes pulling on the bone to make it move. Ligaments are just connections, trying to support your joints. So the ligament is, if it's incompetent, in other words, it's not doing the job of keeping the joint together, then you get instability. And just like you can have shoulder instability or elbow instability, you can also have ankle instability. That happens with severe or repetitive ankle sprains left untreated. So these are the ligaments that make up the lateral ankle, which is the most common type of ankle sprain. If you look at, remember we talked about the heel, so just a frame of reference. This is that big bone, the two-ton tibia. This is the small bone, the fibula on the outside. And all these white areas are collagen tissue, which makes up the ligament. The front one, which is where the arrow is now, is the most often and initially injured, and that's called the anterior talofibular ligament. Blah, blah, blah. That doesn't really matter. ATFL, that's a lot easier to say. So we'll go with that. Next one, the CFL. That's the second one that usually goes for more severe sprains. And then finally in the back, posterior talofibular ligament. That would be a pretty severe one if you tore that one too. But that's the basic makeup of it. You might say, well, yeah, that's on the outside, but what about on the inside? I've had pain on the inside before. Well, that's true. There is another ligament over there. It's called the deltoid ligament. It can often be sprained. It's less common, than the other one. But this is the makeup of that one. There's just a superficial and a deep component, and that goes between the tibia and what's called the talus. So on a true ankle sprain, there shouldn't be any real bony pathology. In other words, we get x-rays to make sure you didn't fracture, but the x-rays should be normal. And if you were to get advanced imaging for this, in other words, an MRI, then you'd be able to look at that, and in a similar fashion, remember that Lisfranc ligament, it's a black line that will be distorted. It'll be all grayed out, it'll be nebulous, it just won't be there. What do we do for an ankle sprain? Initially, it depends upon where you start. So if you're one of those people that is walking day one, not a big deal. All right, maybe you need a brace to protect it. Maybe you don't. Maybe you just need physical therapy upstairs. Maybe you've done it before and you just repeat, your physical therapy in the past. But if you are in crutches or you can't walk without severe pain, then you're going to get a boot. So it depends on how severe it starts with, and then you'd start with where that level is. So let's just say the boot being the most severe. Once you've done the boot and you start to feel comfortable in the boots, in other words, able to walk and get around pretty reasonably, then we ask you to start coming out of the boot, and usually people will transition to a brace. And that's called an ankle stabilizing brace, or an ASO for short. But essentially, it controls the ankle, just not as much. It's not like a cast, it's flexible and it goes into a shoe. Usually at that point, you'll start to continue to improve, and then once you feel pretty comfortable in the brace, then we ask you to start doing some more rehab. Usually if you start the rehab too early, can't even walk around in a boot, it's not going to be worth your time because you won't even be able to do anything. But we do ask you to try to get out of the boot fairly soon. We don't want you in a boot for weeks. We want you in a boot for days to a week, 1 week. And then the physical therapy starts, and we'll talk about that a little bit later. But usually a normal ankle sprain, I would say, should go away 90% by 4 weeks. And most do. If it doesn't hit that mark, then we start asking questions. Why didn't it go away? Is there anything else going on? Is there another injury that we don't know about? And we start getting that MRI study, or at least seeing you back to talk, what is the deal? Surgery for ankle sprains, that's been reported, but even in a professional athlete, you don't really start with that. That's not the standard of care. If we went to surgery for all ankle sprains, I would never go home. There is a standard at which most of these will get better, 85, 90%, and so we try those measures first before. This is the big dreaded boot, and this is the lesser immobilized ankle brace. And this is all that good BT. Okay, so once we get to prevention, what are you going to do as you rehab and get back to activity? Well, it's a matter of flexibility, but it's also a matter of strength. And as we talk about the therapy, proprioception with these ankle sprains is particularly important. In other words, the agility of the ankle, teaching your brain to know where the ankle is in the world and be able to react quick if it's not in the right spot. That's essentially what proprioception means. And so, bracing, this is an athletic tape maneuver, just to give you a demonstration. Those are all the appropriate things while you're trying to achieve those measures to get back. Do you guys have any questions with that? Nothing. Okay, so another one that'll be common around here, I just thought we'd close out with stress fracture, and then if there's any questions, we can go to that. So stress fractures are very common, and you want to think of them as not a yes or no answer. In other words, what I mean by that, it's either, the bone is fine or it's broken in two pieces. Not really the case with stress fractures. They usually aren't all of a sudden maneuver. They're the pain that builds up with time, and we associate that with repetitive injuries, repetitive force, or just activities that are maybe abnormal for you. Maybe you've changed your diet. Maybe you're low on vitamin D. Maybe you're postmenopausal now. There's so many factors that can play a role in this, and that's just something that when I see a patient, in the back of my mind, I'm thinking about, and it's something that we want to evaluate in the long term with the treatment. But it does come down to, usually it's increased activity. Maybe there's something in the metabolism that might be changing the patient. Maybe there's a jump in the deep end mentality and there was some poor conditioning. Or maybe the shoe just is the wrong shoe, or maybe it's just the wrong type of equipment. This is just one common area. We'll see, I would say, any pain on the top of where your forefoot is, and that means basically between the toes and the middle of your foot. So you can remember where that Lisfranc ligament was, it's below that. I would say about 90% of things, pain in that area on the top of your foot, there is probably some bony stress involved with that pain. It's not really another area that has a lot going on. So, similar fashion, we try to see how bad your pain is. We want to make sure that we get you into a spot where we can get you around, keep you active, but at the same time diminish your pain into a really minimal or none environment. And so that means that we're going to be evaluating you for how much swelling you have, how much tenderness. Having pushed on thousands of these, I kind of know what to expect, whether it's really bad or if it's just kind of bad. And then we look at the x-rays. If this has happened and started in a couple weeks, often we won't see anything on an x-ray. And then we'll just treat you symptomatically. Sometimes if you've come back or it's been going on for a month, then we start to see some changes in the x-ray. And that really depends on how bad the injury is. So if it's a mild stress injury, it's not a true fracture. Maybe it's something we call a stress reaction, where it's not broken the bone, but the bone is still challenged. You may not see anything on the x-ray no matter what the time frame is. But if it is truly a stress fracture, it will take a couple of weeks before you start seeing something. MRIs and other studies called bone scans, those are much more sensitive for any type of injury in the foot, upwards of 95, 97%. And so we're really challenged to figure out why you've got all this pain, why is it not improving despite following all the directions, adequate modification of activity, adequate immobilization. Then we go to some of those studies to figure out what's going on. So if you look on the right side of your screen here, this is the same patient, but you're seeing the before and after. And so when we first take the x-ray, you don't really see much. But then you start to see this cloud of bone form. And that is what these start to look like. You might see a little faint line at first. You might see some slight break in the bone on the x-ray, but oftentimes you don't see too much. And then as time goes on, you start to see the body working on it. And that is building more bone. It builds what we call a callus, in other words, a formation of bone around the fracture. And then as that changes over time, it hardens, it becomes more mature. And then once your x-rays look like the bone is more mature, then we can really get you going again. So in most cases, if we do expect a true stress fracture, we'll put you in a boot. Sometimes you get off with one of these little black Velcro orthopedic sandals we give you, but in most cases, the boot is probably your best option. And then sometimes we'll put you, as you wean out of that, into something called a carbon fiber insert. That's just basically a piece of carbon fiber, a hard product which goes underneath the insole of your shoe. I would say that the timing on these varies, so you can have pain improve and get back in a few weeks. That's usually lucky. Usually it lasts longer. And that's when the frustration sets in, but it can take a month. If you kind of go up and down with your activities, it can take 2 months. It can keep going. But the prevention is also a key, and that talks about the proper use of the equipment, the conditioning, balanced diet, of course, talking to your primary if you have any questions about your vitamin D, if you know your vitamin D, just maintaining that. In this particular area, and anywhere really in the northern hemisphere, above Jacksonville, Florida, it's at 30-degree latitude. People are very susceptible to low vitamin D. And then what you'd want to do when you do start feeling this pain is really rest. You have to give it that routine of resting. If you're doing an elliptical or a treadmill, try going to the bike, the recumbent bike. All my patients ask, what can I do? What can I do? I can't sit still. And if Netflix isn't your gig, then you're going to have to find a rower or a recumbent bike, something like that. Or the pool. You can do the pool. Okay, So as we talked, prevention being a big key with these, and I've harped on flexibility as being a big key with these too. Stretching is just a huge part of what we try to train people on. And so that can go to a lot of different things that we see. Yes, it's the plantar fascias and the ankle sprains, but it's also even little irritations in the toe area as well. So flexibility goes a long, long way, and that's something that I would really encourage you to do. I would say probably in, I guess 50% of the things I see, I'm telling people to stretch their calf, stretch their calf. I sound like a broken record, but it really does help in most cases. Okay, so I thought we would just take a quick deviation from diagnosis and prevention and just talk about innovation stuff, just to kind of give you a little sneak peek of stuff that we do a little bit differently than what we did 10 years ago. We're trying to find different ways to treat people in a faster way and in a better way. So we want to decrease your pain. We want to do it with smaller incisions, and we want to make it a less discomfort when we do it. So just a couple of things. Let's touch on what we call arthroscopy, or what's called endoscopy. These are where we put little itty bitty cameras in a space of your body or a joint in your body. So arthroscopy meaning a joint, and endoscopy meaning just a space in your body. So this is an arthroscopy of the ankle. You're looking at a probe that is actually just maneuvering and touching the tibia on the top of your screen here, and the talus, which is the other portion of the ankle bone here. You can see in the background that smaller bone is the fibula. So what we're doing is just checking the cartilage to make sure it's appropriate. We will often go to an arthroscopy when there's injury in the cartilage or when there's damage to the tissue, and if there's unstable portions of that, that is a pain generator. And what we want to try to do is get it back to a stable border. So what this is showing is just us teasing away some of the instability. This, what is biological medicine? Well, this is kind of trying to show you that whole PRP thing I was telling you about. PRP is from the peripheral blood. But we also do some bone marrow. It's almost like a bone marrow biopsy. We actually take it from your pelvis. I do that for a lot of surgeries because I want good milieu. I want good pluripotent, what we call, cells that can form anything. And I put it in the bone graft that I'm putting in somebody's foot when I do various surgeries. And we can do that by actually drawing blood through a little poke hole and a little sheath out of the pelvis, a couple millimeter incision there, and then we mix it, centrifuge it, and we put it in the bone. And so instead of taking a big just incision or a big whack to part of the bone to get graft, we can do some more minimally invasive things. And then finally, total ankle replacement. What is that? Well, you talk about knee replacements and hip replacements, shoulder you may have even heard of, ankle replacements. Well, 1% of all replacements are ankle replacements. And it's trying to mimic a joint that is not just a ball and socket like a hip. It's not a hinge, which just goes up and down like your knee. It's something that goes up and down, side to side, all around in a circle. And so that's why we don't do it as much, because it's usually reserved for more of an elderly population. But these are some of the things that are out there and have become more successful in the last 10 to 15 years. So all these areas are current areas which people do arthroscopy for in your ankle, but we also do it in the back of your foot, which is called the hindfoot. We do it actually into the forefoot too for various types of injuries. So this is kind of a cool video where there is a loose piece of cartilage, and what we're trying to do is just characterize it, but also eventually remove it. Kind of gives you an idea of how tight some of these ankles are. They get a little arthritic. This is a curette that we're using to remove completely the piece. And now that it's loose, then we can remove it. And you can't really see too much here, but I'm trying to dig out some of the loose gravel. Think of these as like a pothole on a street. So you got loose pieces in the pothole, and when they fix the pothole, they want to remove all the bad, and then they fill it in with that fresh asphalt. So what we're doing here is just trying to clean up that pothole. This is just another example. On the back of your ankle, sometimes we'll do some endoscopy, and there was one paper that said 5 months versus 47 days, hey, we're back. In other words, it's just saying that we can get you back faster with some of these methods. Going over the PRP again, yeah, Tiger Woods, he's had about 1,000 surgeries now. He's done this several times. Oh yeah, so this is what I was referring to with some of the bone marrow. So on the right is what I do now. On the left is probably what we did. Some people, sometimes you have to do that, but that's not really my traditional way of getting bone from a patient anymore. I don't have to take a big whack and get a piece of bone. We'll take a piece of cadaver bone that has no cells in it, so it's healthy to the patient, and then we populate that bone with your bone marrow. Just like in a cancer patient who takes a bone marrow biopsy, we take your bone marrow as well. And then we mix it, put it into the bone graft, and we put it in your foot. So, lots of trauma in ankle arthritis. That's the most common reason people get ankle arthritis. This is a kind of a cool picture. Why do we care that you sprain your ankle all the time if you don't have pain? Well, this is why. If you roll your ankle enough, and over the several years, and you've basically made this ligament between your fibula and talus incompetent, then you're at risk for ankle arthritis. So this is just a video showing one of the several ankle replacement options out there. This is what it looks like before in a normal patient, arthritis, and then this is kind of what happens when you put one of these guys in. So you put this jig on, and then here comes the implant. After we've made all these little bone cuts to prepare and resurface the joint, impact that guy in. And then we will slide the tibial component in. So you can think of these, as with any replacement, as you're trying to resurface it. These are made of what's called cobalt chrome metal, and then the white portion is a polyethylene plastic. This is what they look like on x-ray afterwards. All right, that's all I got. Questions? Is anybody awake? Yes?
You didn't mention stem cell therapy.
Yeah, so you have to be careful with stem cell, the word stem cell. So the American Academy of Orthopaedic Surgeons, the AOS, which is what we're governed by, we have no evidence that I can regenerate cartilage. We have no evidence that putting this milieu into you, the stem cells survive. So when somebody says, I'm going to put stem cells in you and make you heal, you got to be very careful with that verbiage because it's not necessarily true. So this is technically what people do when they're talking about stem cells. But stem cell treatment lends itself to, the verbiage is a little off, I would say, from the standpoint of what actually stem cell is. Yes, bone marrow does have stem cells, but how many survive and actually do things, we can't prove that yet. So usually we think this works because there's something called, just like your endocrine system, I don't know if you ever heard of your endocrine system, which is basically your body's way of signaling throughout your body. This is what's called a paracrine effect. In other words, we put the good stuff in the area you want to heal, and that tells the body where to go to heal. So the stem cell idea is, it's kind of like Camelot, where it's there, but we can't really prove it, if that makes sense. Anybody else? Yep.
So I do have an Achilles issue.
Yep.
It's unpredictable. It's like a very sudden onset either when I'm walking or running. So I haven't really done too much about it. I guess it doesn't happen frequently enough for me to be like, oh, I should get this looked at. I guess it's just weird though. I
So-
haven't been running, I just have to stop, it hurts so much, or I walk and then I start, kind of limping a little, not walking in a normal gait.
And for somebody like you, you're not going to be the one that says, oh my gosh, every step of the way, we're really struggling, right? So you would be more akin to some of those other more early on treatments, like trying a temporary heel lift, going aggressive on some of the flexibility. If you don't have any medical issues with anti-inflammatory, now Voltaren, which is diclofenac, is over the counter. And the prescription strength is a little bit lower than what I prescribe, but you would apply that topically. So I would start with that kind of thing first. And if you're not getting anywhere, then you could look into some of those other options. In other words, if yours is mild, so maybe those other non-surgical things that we were talking about might work better for you. But usually in these, it's not cancer. We're trying to help pain and function. So you have to weigh out what's the length of the time or interference with your life and how bad it bothers you to what is available for you. But I would start with that thing first, all those couple little things we just talked about, and then see where you lie. See how much it bothers you and if it's worth it doing something. Just a real quick caveat with Achilles, everyone's worried of rupturing the tendon. The theory is that Achilles tendon rupture, some people believe that all Achilles tendon ruptures come from problems with the tendon. In other words, if you had a perfectly normal 12-year-old tendon, it's impossible to rupture it. Who knows? But the idea being that if you have some pathology in your tendon, you probably have about a 10 to 15% chance risk of rupturing it. But as I tell patients, what are you going to do with that information? Are you going to not walk? Or are you going to stop your life? If it ruptures, it's a random, unlikely occurrence, and then you just address it when it happens. But I wouldn't worry about that. Is my point. Yeah. Anybody else?
You were talking earlier about pain across the top of the foot.
Yeah.
You said 90% of the time it's typically like a stress fracture. As far as the other 10% of the time, what type of categories might that be? And reason I ask is occasionally during a run, I'll start to feel that as the pain, and typically mile, 2 miles in, everything loosens up, and I no longer feel like that over the top of the foot pain.
So it depends upon the age. So if you're older, then I'm thinking more arthritis. That's not really you. So it could be where the shoe even pinches on a nerve. It could be that your arch is a little one way or the other. And so you tend to apply a little more force on maybe the outside of your foot. And then over time, the foot doesn't like that. And so we have cases where we just kind of tweak you with you putting your foot in this position a little more, and then you feel better.
Okay.
So I mean, if it's one of those where it's just a little bit of a tweak here and there, I would think about doing something, a little change in your shoe modification or a little insert modification, and see where you lie with that before you really kind of dig in.
Mm-hmm.
Yeah. Yeah.
Thank you.
Okay, cool. Thank you very much, guys.
My name is Anya. I'm a PT. I work upstairs for TriHealth Orthopaedics and Sports Institute, and I'm here to talk about the rehabilitation aspect of foot pain and foot pathologies, and give you guys a little bit of insight into maybe some self-tests that you can do. I have a handout brochure up here. You guys can take home and do some of these at home, and then give you some other considerations for some prevention and help keep you pain-free. Keep your feet in running order, if you will. Oh, that's not what I wanted. There we go. All right, so just a couple of facts about the foot. Just to kind of give you an idea of some of the different factors that we have to consider initially about your foot and ankle. So the ankle sustains the highest loads are the highest forces of any ankle or any joint in the body per surface area. You think about it, that's not really a hard thing to think about considering how small your ankle joint actually is. But you think about when we're walking, going through your daily life, it's 1.5 times your body weight typically with a walk, and up to 3 times your body weight with any sort of high intensity activity like running. That's a lot of force going through a very small joint. There's a lot of articulations in the foot. There's a lot of structures that are trying to keep you stable. All of these things have to accommodate for how your foot is hitting the ground, the different surfaces that you're hitting, how the shoes that you're wearing, all of these things. It's really having to adapt to a lot of different things. Not only is it having to resist the forces that you are putting on it, but it also has to resist the forces that the ground is putting back on your body, right? For every action, there's a reaction, right? So there's a lot of things that it's having to account for. 2/3 of the forces are absorbed through the hind foot, or kind of the back part of the foot, where Dr. Miller was talking about, kind of through the calcaneus. And then about 1/3 are through the metatarsal heads, and we think the metatarsal heads are kind of where this big bony joint is, where the toes articulate with the ball of your foot there. So when we have somebody that comes into the clinic with foot pain, what are we going to do? What does that look like? A lot of times when people come into us with foot pain, especially with a lot of your endurance athletes, CrossFitters, a lot of times these are pathologies that we have to account for, but typically these are symptoms of deficits further up the chain. So we're going to look at your entire body. How is everything moving together? How do your hips move? Are your hips dropping when your feet hit the ground? How does your foot hit the ground? Does the back of your foot roll out? Does your arch cave in towards the floor? Do your hips drop? Are you pigeon-toed? Do your toes splay out? All of this comes into effect, right? So we're going to look at how you move. Deficits further up the chain contribute to force distribution at the ground level, right? We're going to look at how you walk, all of these things that I just talked about. Dr. Miller hit on the big toe mobility. Are you able to roll all the way off of your toe? That's kind of a big deal. If you think about the plantar fascia ties in at your big toe. If you don't have good mobility there, you can put stress on your big toe, you can put stress through the ankle, put stress through your plantar fascia. All of these things have to work and play together. They have to play nice, or else we start to have pain, right? Look at dynamic versus static stability. How are you moving? How are you able to stabilize yourself while you're moving versus when you're static? Standing on one leg, can you do a single leg squat? What does it look like when you just do like a functional sit out of, or stand out of a chair? All of these things come into play. Strength, again, kind of some of that comes in with, like functional testing, like squats and that kind of thing. What kind of motion do you have at your ankle when you squat? You have to have that good ankle mobility to be able to do a full squat, that kind of thing. Plus, we'll take you through a series of tests where we can put you in a position. Are you able to hold that position versus being able to do something like that single leg squat I talked about? We'll talk about that a little bit later as well. And then balance. I don't know how many times I've had runners, cyclists, CrossFit athletes come into the clinic and they're like, I've got crappy balance. Well, maybe you should work on that. You think about all of these activities, how you have to stabilize yourself when you're doing these activities. Running in and of itself is a series of standing on one leg. If you can't stand on one leg, just standing still, how is it going to look when you're running? How is your body stabilizing itself? Probably not very well. These are aspects that we kind of look at. And if you've come into the clinic, maybe you haven't seen the doctor, or maybe you haven't had imaging, we're also going to make sure that your foot pain isn't coming from somewhere else, whether it's the back or farther up the chain, these kind of aspects that can contribute to the foot as well. So just a couple of pictures. We talked about some of the different motions of the ankle, that dorsiflexion, bringing the toes up towards the shin. That's one you've heard a few times tonight. We'll look through the gait pattern. Standing on the leg for about 60%, swinging for about 40%. Again, lots of things that go into that motion. How does your arm swing look? How are your hips looking? There's a lot of things that we can kind of glean just from watching you walk, right? And then just some some functional tests, or even kind of looking at different activities that you might be doing through lifting or other activities, right? Do your feet flatten out? Do your knees cave in? Do you have to like compensate for a really forward shoulder because your ankles aren't moving very well? All of these things are considerations. So that's where we kind of talk about this movement analysis, that dorsiflexion mobility, being able to bring the toes up towards the shin. Just have to be able to move that tibia over the foot. That can limit us in positions like a squat, where you have people that do a lot of these activities, or they're doing these activities really repetitively, right? That also we'll look at. So also kind of looking at maybe how you run and what your run looks like. Are you able to stabilize yourself? What does your cadence look like? Again, how your feet are hitting the ground. All of these things can kind of give us indicators as to where the pain is coming from or what could be contributing to your pain. So I give just a couple of self-tested here. I was going to talk about, again, there's some instructions up here if you want to take them and do them at home. I have a couple of stations set up here so you can try them before you leave if you want to run through them with me, or if you have questions on them, feel free. So the first test here, standing with your toes on a piece of tape. I have tape marked out in inches. You can do it on a tape measure, however you'd like to do that. Standing really straight and still, everything moves straight forward. You're going to try and bring your knee to the wall, starting about 2 inches or so from the wall, and then you're going to work your way back inch by inch until you can't touch the wall anymore, and you're not having to deviate or throw your hips to be able to touch the wall. Normally we should see about 5 inches or so. That's normal. If it's less than 3, that's fairly limited. But you can also compare this from side to side. You just might be a tight person, and that's okay. There's nothing necessarily wrong with that. But if you have big deviations from side to side, that could be an indicator that one side's maybe having to compensate for something. It's the big toe mobility. Dr. Miller kind of hit on that. That's definitely one that we will look at again. There's a lot of things. We have to be able to roll through the toe. We have to have a really good lever for that push-off. If we don't have good toe mobility, you might have to compensate with rotation of the foot or farther up the chain, diving that knee down, all of that. So you should have about 30 degrees of toe mobility there. That's kind of a hard one to measure, but that would be, again, you can kind of look from side to side. Is one side really limited versus the other side? Is it really stiff? Definitely something to consider. So strength through the calves, just standing on one leg. You're going to try and do as many calf raises as you can using something to hang on to. You don't want to push through it. You just want to raise your heel up as high as you can. Roughly should be about 25 to 30. But again, compare side to side. What does it look like? What does it feel like? Are you able to do them? Is it really challenging? All of these things. And then last one, my lovely self, because my lovely assistant wasn't able to take this picture. A single leg squat. Again, we can look at you functionally. How are your hips stabilizing you in doing this position? And a lot of these things come into play with these repetitive activities as well. And if you're not able to hold yourself stable, or your ankle's not able to move past, or your tibia is not able to move over your ankle, I can limit you in a lot of these things. So just, again, some of these are really easy. Just some ideas for exercises, right? The test now becomes the exercise. Kneeling, just rotating that tibia over, stretch that calf out just a little bit. You can also stand on a stair, let your heels drop, however you feel comfortable doing a calf stretch, right? And if you have questions, again, feel free to ask, okay? Heel raises, again, test becomes the exercise. Really easy. I like doing them off of a stair because you get mobility at the same time. So we can get some good calf length, we can get some good stretch through that Achilles and through the gastroconsolius, as well as getting a little bit of strength there. The big toe mobility, you can literally just work on big toe mobility. Stretch it out. Sit in a chair, cross, move the big toe. If you want to mobilize your plantar fascia just a little bit, you can use a ball at the same time. Hit those points that are maybe a little bit tender. That's okay, as long as it's not like awful pain. You should be able to tolerate it well as well, right? Don't go home and put yourself through misery because I said try it, okay? And then do the big toe and then kind of roll the ball along that plantar fascia, so you're getting a little extra stretch with that. And then the balance aspect of it, incorporate balance into your strength program, right? A lot of people, a lot of endurance athletes don't like the strength program. You should do a strength program. You should have a good strength program 2 to 3 times a week to make sure that you're able to accommodate, again, these forces that you're putting on your body. When we use our balance from day to day, we typically don't just stand here and say, oh, I'm going to balance here right now. That's not how it works. We're walking through the grocery store, we're standing on one leg, we're looking side to side, our balance is always working. We're running, we're hitting different surfaces. This proprioceptive aspect where we have to have our ankle tell our brain where it is in space. We need to be able to use that. If we don't have that good balance, that good feedback from the brain to the body, it puts ourselves at more risk for injury. So that's definitely something. Incorporate some single leg deadlifts. I have just a T here, making sure everything stays nice and level. Work that single leg aspect into your strength program. It's a really good way to work your balance as well. And then hip strength. My coworker in the back can attest that this is my favorite exercise ever. You can use it for everybody. I use it for back people, I use it for knee people, I use it for hip people. Use this band. You can put it at the knees, you can put it at your ankles, you can put it all the way around your feet. Around your feet, it's going to work through the glutes just a little bit more. Vary it up. Not one is better than the other. Doing something is better than nothing. Try all the variations. Add multiple bands, however you want to do it. And then other considerations for exercise. How many people know somebody that has a closet that looks like that? I do. Right there. He's guilty. Shoes and orthotics. We have lots of people that ask about shoes and orthotics. There's actually a recent study that came out that there is some evidence to suggest that stability shoes can help prevent pronation-based injuries. Pronation is where that arch kind of collapses down to the ground. Does that mean you should go out and buy stability shoes because I just said that? Not necessarily. If you're comfortable running in a shoe, you don't want to change your shoes. I'm not here to tell you not to do something. I'm here to help you get back to what you want to do. Everyone's a little bit different, and I know that runners are really superstitious about their shoes, so don't tell them to change things, right? Orthotics definitely can be beneficial, especially for these repetitive-based injuries, plantar fasciitis, Achilles tendonitis. We want to offload those tissues for a little bit. My goal is to help you not potentially have to rely on those orthotics, but use the internal stability structures that we have to be able to stabilize your body. Use a strength program. We can definitely add different exercises in. There are muscles that help support your arch, that help decrease that rate of pronation so we're not driving down to the ground quite so hard. When we start to work on that a little bit. That gets a little bit more technical, so I didn't leave that in there or didn't put that in there, but again, if you have questions about it, please feel free to ask. We see a lot, especially people who are these endurance type athletes, that get into trouble with these issues when we start to change a lot of variables at once. Don't change too much at once. Like, don't go out, I'm going to go buy new shoes because I need new shoes, and then I'm going to go run hills, and then I'm going to go increase my mileage by 20 to 50% next week. Don't do that. Gradually increase your program over time. Allow your body to adapt to the stresses that you're putting on it. Your body is a very adaptable being, and it can and will adapt, and if you make it more resilient through a strength program, which I mentioned earlier, and just adding different aspects into your program, but not doing it too quickly. Let your body do some of that work. And then again, with resistance, you see people that want to go from doing, yoga and Pilates to doing CrossFit or these high intensity exercise. That's fine. That's great. But make sure that you use modifications as needed. Just because Joe next to you is doing 20 burpees with a full push-up and then going and doing 80-pound deadlifts, or probably a lot more than 80 pounds, doesn't mean that you have to. Gradually build into it. You don't have to go super crazy. You don't have to kill yourself. And don't go through pain, right? Especially our endurance athletes. Don't run through pain, right? Use activity modifications as needed. You shouldn't progress through your program unless you can do so without pain. If it's painful at a certain level, maybe back off just a little bit and then gradually increase back, right? And that's where we start to get into those chronic issues, right? Where we see these really repetitive activities. It starts with pain and like, oh, I just ran through it. And then it starts to become a chronic thing where you start to get into tissue breakdown, and then eventually we have to, do some not very fun treatments, right? So that's all I have for you today. If you want to try some of these tests, like I said, feel free to come up and I can kind of run you through them, or if you have any questions on them, you feel free to come see us. If you have foot pain, we do accept people direct access in the state of Ohio, so you can come see a physical therapist. We love our doctors upstairs. We can definitely do a screen, and if we deem that there's something that maybe needs further workup, we will send you over to the doctor for sure, unless you have Medicare. Medicare requires a doctor's referral. So here's our number, and here's my running buddies. Back before our old man could actually walk, or couldn't walk, I guess. He doesn't walk very well anymore. And I'm not talking about my husband. You're right, I do lie. Are there any questions? Sweet. Dr. Miller and I answered them all. Go us. All right. Feel free. I have cards up here. Like I said, I have some of these handouts as well. And if you need anything, I will be around here shortly.